Now, when a patient comes with eclampsia, the three main headings under which management follows, all right, is number one, seizure management, that is control of the seizures and prevention of further seizures from happening. Secondly, because the cause is preeclampsia or hypertension, we have to manage her hypertension also. And of course, the obstetric management, because we all know this, that it is a rule that if a patient has preeclampsia or eclampsia, the final delivery of the mother. Physiology is the pregnancy itself. Once we deliver her, everything else should settle back to normal. So the three headings under which hypertension, eclampsia is managed, I will repeat, are seizure management, hypertension management, and obstetric management. Now, this is just a chart which I thought was a good way to explain what needs to be done. So I will. So this is the timeline. So when a patient comes with eclampsia, approximately this timeline needs to be followed in the initial bit of the first 20 minutes. So the first 5 minutes would involve immediate patient, that is stabilizing the airway, getting avoiding steps to avoid maternal. This would be the initial 5 minutes, along with preventing recurrent convulsions, and we all know the drug of choice for that is magnesium sulfate. The substitutes still follow the. So I will be describing this regime and other low dose IV regime. Next, once the seizures have been managed, hypertension. Okay, because in has recurrent convulsions, and if she is stable, assess how stable she is, and then we plan for the obstetric management, that is preparing her for delivery, or if she's in a primary center, referring her to a medical center with ICU and obstetric emergency obstetric care wherever available. So this is a flowchart which I thought was good, and I will refer to, as I said, I will refer to it time and again in this presentation. Now, there are two scenarios which a patient can present with in the labor room. One is she can directly, the patient is brought in the post-ictal state. She's had a seizure at home or wherever she's being referred from, and then she comes to us and she's brought to us in either a post-ictal state following a seizure at home or a health center. And this is a common scenario. Another common scenario, which actually should not happen if the patient is with you, eclampsia, please remember, is mostly a preventable condition. Very rarely you can't prevent it, but yes, most of the times it is preventable. So this should not happen if you have been managing her severe preeclampsia well. So the second scenario is the patient has a seizure right in front of you in the labor room or in the ward in the hospital setting. So these are the two scenarios with which the patient can come. So in the first scenario, the patient is brought following a seizure. What do? We initially assess the patient clinically. We obtain history from a reliable, but of course, the patient won't be able to give a history. We need to know her parity index. We need to know her gestational age. So whenever a patient comes to us, the first thing you need to remember is, before you go into this actually, is to have a proper team. There should be a person who is assigning or has assigned work to do. For example, the main person, the senior resident in the labor room, can assign an intern or a junior resident or a nurse to go and obtain a quick history from a reliable witness. When did the seizures start? How many seizures has she had? Is she on any antihypertensive drug? So check all her records. When was the last ultrasound? And what medication has she received before coming here? Has she already received the loading dose of magnesium sulfate? So one person needs to be involved with taking history from a reliable witness. The other team members should divide themselves into different parts. Okay, and what does that involve? One important thing is assess the consciousness of the patient, monitor her vital signs, very importantly her pulse and her blood pressure, auscultate the chest, look for signs of pulmonary edema, check her deep tendon reflexes, are they brisk, secure an intravenous line, catheterize her for monitoring urine output. This is after her seizure episode, after the patient comes in a post-ictal state. Monitor her for recurrent seizures, pulmonary edema, abruption, acute renal failure, DIC. These are all complications which can happen with severe preeclampsia, eclampsia. So this is the initial assessment which has to be done within the first few minutes of the patient coming. The second scenario is the patient is having a seizure right in front of you. So if she's having a seizure right in front of you, what will you do? So that is acute care during a seizure. Okay, so what do? You give supportive care, number one, to prevent maternal injury. If she's on a, ideally severe preeclampsia, eclampsia patients are kept on a bed with side railings. So put up the railings if they're not already put up, or put pillows around her so she doesn't end up injuring herself. Okay, make sure the railings have to be padded. Do not try to hold the patient down or stop their movement. That will only worsen the situation. So do not hold the patient down, do not try to stop it. Just make the surroundings around her more comfortable so she doesn't injure herself. Use a mouth gag to avoid tongue bite. So initial steps are these. So supportive care to prevent maternal injury. Second is check the airway patency and ensure oxygenation. All right, so make sure her airway is patent. How do you do that? By suctioning out secretions which the patient may aspirate. So put the patient in a lateral decubitus position and suction the oral secretions. Then you can maintain oxygen by giving her, maintain oxidation by giving her oxygen 8 to 10 liters per minute. And so although the initial seizure lasts only for a few minutes, but even in those few minutes, if her saturation drops, that can lead to significant consequences on both her and on the fetus. So make sure that oxygenation is maintained, and we can use a pulse oximetry to check the saturation. So that is the initial treatment. So initial treatment, as I said, the patient will be brought to you in a post-ictal state, post a convulsion, or she has a seizure right in front of you. This is the initial thing what needs to be done. Now, treatment coming next, remember the charts, and after the first 5 minutes are done, you managed all this. Next comes magnesium sulfate. So magnesium sulfate is the drug of choice to prevent subsequent convulsions in women with eclampsia. Also, it is used in prophylaxis of eclampsia in women who have severe preeclampsia. So magnesium sulfate, you should know in detail. You should not be sitting and calculating how many ampules to sit and give now once the patient comes. So once the patient comes, I said one team member takes history, one team member assesses her situation, does the steps I mentioned earlier. One team member prepares the magnesium sulfate. So all this should be done going on together. Okay. So what do we follow? We follow the Pritchard's regime, although for a few patients, the Zupan regime also has been given. So I will be describing both. Okay. So the Pritchard's regime basically says we give a IV and IM loading dose followed by intramuscular maintenance dose. Okay. So remember a few things. Once when we give IV magnesium sulfate, the concentration should never exceed 20%. Okay, but please remember magnesium sulfate is usually available as 50% concentration. Only very few institutes in India and the world over have made a sample of 20% and have kept that ready in the labor room. And I've worked in such institutions, but most other institutions where I've worked in do not have 20% readily available. So it is available as 50% concentration. So each vial of that 50%, remember, has 1 gram of magnesium sulfate, and that contains 2 ml. So 2 ml has 1 gram, and that is why the concentration is 50%. If 2 ml had 2 gram, it would have been 100% concentration. So what does 50% concentration mean? It means that 1 gram in 2 ml is 50%. Okay, so this is how the magnesium sulfate is available, what we have. But remember, when giving IV, we never give such a high concentration. We have to reduce or dilute the magnesium sulfate to make it 20%. Intramuscular, you can give 50%. IV, you can give only 20%, and it has to be diluted. That is the main thing you need to remember. So as I said, what are the doses we give? Pritchard's regime, the loading dose is 4 grams IV of 20% magnesium sulfate. Okay, so 4 grams is the intravenous dose and 10 grams is the intramuscular dose. As I said, IV has to be 20% and IM has to be 50%. So we give a total of 14 grams in the loading dose. The maintenance dose is then given 4 hourly, 5 grams intramuscular and alternate buttocks. This is again 50% magnesium sulfate. Till when do we give it? Till delivery of the patient or the last seizure, whichever is later. So that is how we give magnesium sulfate. Now a bit more describing exactly how to make the dilutions and how to administer magnesium sulfate, and this should be on your fingertips. You should not be start calculating and thinking or opening my PPT at that time. You should be able to do this. So you have to know this on your fingertips. All right. So how do you make 20% magnesium sulfate from 50% magnesium sulfate? So let me make it simpler. Here you can see there are 4 ampules of magnesium sulfate. This is 50% magnesium sulfate. You have 1 ampule, 2 ampule, 3 ampule, and 4 ampule. Each ampule I said contains 1 gram. So 1 gram plus 1 gram plus 1 gram plus 1 gram is equal to 4 gram. And this is in how much ml? Each is 2 ml. So 2 ml plus 2 ml plus 2 ml plus 2 ml is equal to 8 ml. So here we have 4 grams in 8 ml of 50% magnesium sulfate, right? So what do we do now? We dilute it with distilled water. Okay, we dilute it with distilled water. How much distilled water? We dilute it, one second, we dilute it with 12 ml of distilled water. So now we have a 20 ml solution, right? 8 ml plus 12 ml. We have a 20 ml solution containing 4 grams of magnesium sulfate. And what percentage will this be? This will be 20%. Okay, so this is how we make our 20% magnesium sulfate from 50%. So this is 4 grams in 20 ml, which is 20% magnesium sulfate. I will repeat for those of you who are still not comfortable or not understood. So we have 4 grams in 8 ml, 50% magnesium sulfate, then 12 ml of distilled water, and then this becomes a total of 4 grams in 20 ml, which is of 20% magnesium sulfate. So basically we dilute the 8 ml with 12 ml of distilled water. So you should have 4 ampules in your hand to give the IV dose. Dilute it with 12 ml of distilled water and inject that slowly at the rate of 1 gram per minute. So over at least 4 to 5 minutes, it has to be inserted very, very slowly, slow intravenous. Now, okay, so coming to the, again, let's recapitulate this. Okay, so this is 4 grams in 8 ml plus 12 ml, and this becomes our intravenous loading dose of 20 ml 4 gram. All right, now this is how many ampules? See, 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. So this is 10 grams of how much? 50% magnesium sulfate. And how many ml will this be? Because there are 10 bottles, 10 into 2, 20 ml. So this is also 20 ml. This is our loading dose intramuscular. So see, the IV loading dose is also 20 ml because we diluted it, and the intramuscular dose is also 20 ml. And if of this we divided it half, 10 ml in one buttock and 10 ml in the other buttock. Just hold on, just give me a minute. I have to put my laptop on charge. 2 minutes. Sorry. As I was saying, loading dose is also 20 ml IV and intramuscular is also 20 ml. The only difference is we have to dilute the 4 grams, which we give IV, with 12 ml saline, and the intramuscular dose, which is 10 grams, is given as same 20 ml, okay, without diluting because it is 50% and we need 50%. So this is how we give the loading dose. The next is the maintenance dose. Okay. Okay, so the maintenance dose is, as I said, it is 5 grams intramuscular, 50% magnesium sulfate, 4th hourly. Okay, so here we have 1, 2, 3, 4, 5 ampules. This will be 10 ml. So 10 ml in alternate buttocks every 4th hourly. But before giving, and I think we all know this now, we've been learning this since undergraduate days, we have to check the patient's respiratory rate. Why? Because in the event of magnesium toxicity, there could be respiratory depression. Okay, so we do not measure in most centers, and it's also been proven that clinical monitoring of magnesium levels is same as therapeutic monitoring of magnesium levels in the blood. So clinical monitoring is very important. Respiratory rate has to be checked. It should be more than 12 per minute. Okay. DTRs should be present because again, neurological depression can happen with magnesium toxicity. So these should be present, and the urine output should be more than 30 ml per hour. Okay, why is urine output important? So magnesium toxicity does not cause renal failure. Magnesium is mainly excreted by the kidney, and renal failure can be a complication of severe preeclampsia, eclampsia. So if the woman is going to renal failure, she will be failing to excrete the magnesium, and that can lead to a buildup of magnesium in the serum. So that can lead to magnesium toxicity. So we need to ensure her urine output is adequate before giving the further doses. So respiratory rate, DTR, and urine output need to be checked. And as I said, continue till 24 hours of the last seizure or her delivery, whichever is later. That's very important. Okay, now the Zupan regime. So if you have an IV infusion pump, okay, the Zupan regime can also be used. And this is a low dose. It is at the total dose is lower than the Pritchard's regime. So your chance of magnesium toxicity is lesser. So if we have an IV infusion pump, this is to be preferred. What is this dose? This again is the loading dose is the same. It doesn't have the IM dose. It just has the 4 gram, 20% magnesium sulfate. How we prepared it for the Pritchard's? The same way we prepared it for the Zupan. Over 5 to 10 minutes, we give this loading dose. And then a maintenance dose is given. Now, this is the one which is given as an IV infusion. So we give this as 1 gram per hour of 20%. I remember IV is always 20%, no 50% in IV. So 1 gram per hour magnesium sulfate is an IV infusion, and I will tell you how it is prepared. So here we have our loading dose. Okay, so same 1, 2, 3, 4 with 12 ml of distilled water is equal to our loading dose 20 ml, 4 gram, 20%. Okay, so 4 ampules, mix it with distilled water 12 ml. You have 20 ml, give it over 5 to 10 minutes, slow IV. Now here is the important thing which you should know. If you have an IV infusion pump available, what do? We give 1 gram hourly intravenous. 1 gram per hour is given. So how do we prepare that? We take 4 grams of magnesium sulfate in 200 ml of normal saline. So 4 grams of magnesium sulfate in 200 ml of normal saline. And we set the infusion pump at the rate of 1 gram per hour. That is about 50 ml per hour. Okay, so 4 grams in 200 ml. So 1 gram will be in 50 ml. Right, so that is the rate at which we set the infusion pump until 24 hours after delivery or since the last fit, as I said before. So this is Zupan's regime. So here you take, for this loaded, this is the maintenance dose, we take 4 ampules of magnesium sulfate, take a 200 ml NS bottle, take the infusion pump, set it at the rate of 50 ml per hour. Now, alternately, suppose you don't have an IV infusion set. Ideally, you should not use it without one, but it has also been described if you don't have an infusion set and if you have very good monitoring available, what you can do is you can use 12 ampules, so 12 grams magnesium sulfate in 1 liter of Ringer's lactate. So take 12 grams of magnesium sulfate, that is 12 ampules of 50%, mix it with 1 liter of Ringer lactate and give it at the rate of 80 ml per hour IV. That will be the same amount. That will go as 1 gram per hour. So ideally what should you do? 4 grams in 20 ml to 200 ml of NS, set at the rate of 50 ml per hour. If you don't have an infusion pump and you want to give Zupan, put 12 grams in 1 liter of RL and give it at the rate of 80 ml per hour intravenous using an inflow line regulator. So this is Zupan's regime, the loading and the maintenance dose. Loading dose is only the IV, not the IM. Maintenance is preferred if you, so Zupan is preferred if you have a IV infusion pump, and most places these days now do have an IV infusion pump. This is in a way better because it is a low dose regime like the Sibai, Zupan, both are low dose regime, and the chance of magnesium toxicity remains less. Okay, so a few other important points when giving magnesium sulfate, what should you remember is add 1 ml of 2% lidocaine before giving the intramuscular injection. It is very, very painful. So locally anesthetize the area before giving the magnesium sulfate. Now, also remember about 10% of all patients will have a recurrent seizure. So you've done your acute management, you've given magnesium sulfate, but then she has another seizure. What should you do then? What should you do? You should give magnesium sulfate again, but how much? Half the IV loading dose. That is 2 grams IV, 20% needs to be given. So instead of 4 ampules, 2 ampules. So 2 grams IV have to be given, again dilute to make it 20%. Okay, now rarely, despite adequate doses and therapeutic doses of magnesium sulfate, seizures can still persist. What do you do then? You give lorazepam 4 gram intravenous over 3 to 5 minutes. Also importantly, involve a critical care specialist in this scenario. So if your magnesium sulfate is not working, give lorazepam 4 gram IV, but also involve a critical care specialist who will help you manage the patient better. Okay, also look for signs of magnesium toxicity. I've already told you the clinical monitoring, we do 3 things: respiratory rate, urine output, and DTRs. Okay, but so routine monitoring with serum magnesium levels is not recommended. As I said, clinical monitoring is found to be equally effective. But if you do serum monitoring, then I'll just let you know what the values are. So remember, DTRs are lost at a serum magnesium level of 9 milligram per deciliter. Respiratory depression occurs at 12 milligram per deciliter, and cardiac arrest occurs at 30 milligram per deciliter. So if you are getting serum magnesium levels checked, you should know the cutoff values. So patients at risk with impending respiratory depression may require intubation and emergency correction. So we all know the antidote for magnesium sulfate is calcium gluconate. How much do we give? 10%, 10 ml IV slowly over 5 minutes, 5 to 7 minutes, it should be given. Okay, so that's why clinical monitoring is very important, provided that the DTRs, so DTRs are the first to go. So if DTRs are still there, then the likelihood that she's going into serious toxicity like respiration is very less. So that's why your clinical monitoring is very, very important. DTRs, you have to check every 4th hourly, because if DTRs are present, the chance that she has severe toxicity is much, much less. And if you are checking magnesium levels, you can, or if you find symptoms of clinical symptoms of toxicity, then you can check the magnesium levels every 4 to 6 hours. Okay. So when do you check this? As I said, if clinical parameters, if the urine output is less or creat is high, or if signs of magnesium toxicity. Now coming back to the chart, so we are done with, what are we done with? Now we are done with this part, we are done with this part. Now coming to control of severe hypertension. Okay, so control of severe hypertension is our next goal. We have to manage her blood pressure to prevent more complications like abruption, DIC, ARF from happening. So what do we do? Our initial drug of choice is labetalol. Okay, so labetalol is given, and I think all of you know this regime. I'm just revising, because again, it's something which you should know and not open your books and check your phones to see what the dose is. So 20 milligram over 2 minutes is given IV labetalol. Check after 10 minutes with the BP is still not below 160 by 110, repeat 40, so double it. So 20 initially, then 40 over 2 minutes, still not low, then 80. 80 can be repeated twice. So total of 220 milligram can be given labetalol. Okay, some guidelines like the ACOG says after 20, 40 and 80, and if there's still no reduction in the blood pressure, shift to IV hydralazine. Now, IV hydralazine is not commonly available in most places. Okay, so how much do you, if you do have it, this is the next best step: labetalol, then hydralazine. How much do you give? You give 5 milligram IV over 1 to 2 minutes, then check at 20 minutes. Then administer 5 to 10 milligram again. If again after 40 minutes it persists, administer 5 to 10 milligram again. Maximum cumulative dose of 20 to 30 milligram is given. If there is tachycardia, however, stop the hydralazine. So I will repeat: 5 milligram you give, then check at 20 minutes, repeat 5 milligram, check at 40 minutes, give again 5 milligram. Maximum you can go is 20 to 30 milligram. But if despite this hypertension still persists, then you need to involve a critical care specialist, a physician, or a critical care specialist. And then what you do, usually what they do start is a nicardipine infusion, or more commonly in the setups we work in, NTG infusion is started, as I said, in consult with the critical care team. So this is control of severe hypertension. Alongside this, along with the control of hypertension, we have to send the investigations. Okay, because we have to see how severe the how the lab work is, and also how we need to manage the patient. We need to prepare her for delivery. We need to have a urine albumin, which can be done stat. Although the recent ACOG definition now says proteinuria is not essential for diagnosing preeclampsia, but yes, a urine albumin should be done. CBC with peripheral smear. We need to see the level hemoglobin, if there's any hemolysis happening, if there is associated HELLP syndrome, also thrombocytopenia. Her renal function tests, her liver function tests, her coagulation profile, very, very important, because all this will help us in planning her delivery. So this is also done. So we did her acute management. We gave her magnesium sulfate. We controlled her hypertension. We did her lab work. Also fetal monitoring, see if the fetus, if there's any evidence of fetal distress or not. And then that will also help us decide the mode of delivery. So coming to obstetric management, delivery has to be expedited. So remember, it has to be expedited. That does not mean you go and do a cesarean section for every eclampsia patient. So eclampsia patients preferably should be delivered vaginally. Cesarean will increase the morbidity and mortality. So preferably vaginal delivery. But again, that depends on the gestational age she's come, the Bishop's score that she has, how critical she is. All right, so it depends on various things. Okay, any obstetric factors related, maybe she's previous cesarean or maybe she's placenta previa, so then you don't have much of a choice really. So cesarean section, as I said, only for obstetric indication. If thrombocytopenia is associated, we recommend platelet transfusion if the platelet count is less than 50,000. Okay, regional anesthesia is avoided if there is thrombocytopenia or coagulopathy. And general anesthesia in eclampsia, it does increase the risk of aspiration and failed intubation due to airway edema. So of course, this anesthetist will take care of, but we need to keep this in mind. Okay, very importantly, again, is even in preeclampsia is avoid fluid overload. Otherwise, she will go into pulmonary edema. Now, post-delivery, what do? We continue magnesium sulfate till 24 hours after the last seizure or delivery, whichever is later. We continue monitoring of the vital signs, urine output, reflexes for at least 72 hours post-delivery. So ideally, the patient should be in the HDU unit or the ICU if she's on ventilatory support, and continuous monitoring should be done for at least, continued monitoring should be done for at least 72 hours post-delivery. And once she's in the postnatal period, you need to check her, assess her blood pressure, and these are the drugs that can be safely given if she is lactating. So what are the drugs which can be given in lactation? Labetalol can be given. If she was on labetalol, can simply be continued. Atenolol, nifedipine, amlodipine, and enalapril are also safe in the postpartum period, especially if she is lactating. So if she's on antihypertensives, follow her up. If you discharge her on antihypertensives, she needs to be followed up after 2 weeks. And if her blood pressure, her high blood pressure persists at her 6-week visit also, then she needs to be referred to a physician to see if there is any underlying cause for her essential hypertension. So detailed evaluation if she's still on antihypertensives at 6 weeks. Okay, so in all this, one critical thing which I missed, and that's why I actually put at the end, because although I put at the end, it has to go on side to side. So communication is very, very important these days. It is a part and parcel of a doctor's life. It is very important to keep talking. We may not be able to talk to the patient because she may not be in such a condition, but her attendants, her relatives have to be kept informed about what is happening, how critical she is, how the mother is, how the baby is, time and again compared to other patients, the status of the mother needs to be key. We need to keep updating the relatives, and this part many times gets missed out because of the criticality of the situation. But it is very, very important as residents, as primary caregivers in the labor room. Counseling is a huge part of the job that you do. So thank you, everyone. So as I said, medicine is a science, as William Osler said, medicine is a science of uncertainty and an art of probability, but with so much evidence now available, eclampsia should actually be not happening most of the time, because it is very much preventable. Not always, but yeah, most of the times, yes. And if it does happen, we should know what steps to be taken to prevent further maternal and fetal mortality. So thank you very much.